Welcome to Health+Tech, the podcast where we explore the law that applies at the intersection of healthcare and technology. Hosted by McGuire Woods, episodes feature healthcare innovators and updates on the laws that apply to digital health businesses.
Welcome to the Health+Tech podcast. I'm Kristen McDermott Woodrum, a partner in the Atlanta office of McGuire Woods. I'm joined by my partner, Buckley, who is based in Chicago and chairs the McGuire Woods Healthcare Department. Holly and I lead the McGuire Woods Digital Health, Technology, and Innovation practice and are hosts of this Health+Tech podcast. Today, we are excited to welcome to the podcast Roman Sandler. Roman is the CTO and co-founder at iCardio.ai, where he leads the AI team. Roman earned his PhD from USC in biomedical engineering, focusing on the intersection of machine learning and computational neuroscience. Prior to iCardio.ai, Roman spent over a decade working in and leading AI computer vision teams in the biomed and defense industries. Welcome, Roman.
Thank you so much, Kristen and Holly. Great to be here.
Roman, tell us about yourself, your scientific interests, education, and career path, and what led you to move from working on military-grade AI to co-founding a startup that focuses on AI and echocardiograms.
Yeah, sure. So I guess I got my start, originally what I really wanted to do was neuroengineering, brain-machine interfaces, and that's what I went to grad school for at USC, working with Ted Berger and Bacillus Barbarellus. And, it kind of fortuitously, even though that wasn't my intent, I ended up actually never working with any real brains. I was sitting in a room all day on a computer, essentially learning from brain data, doing machine learning with brain data. And, looking back, that was very fortuitous because it got me into the machine learning space very early before, even deep learning was a thing. So after grad school, I worked in the neurotech industry. I was a founding member of a startup called Kernel. And then they pivoted and I had to get on the way, needed a job. So I just landed a job in defense. Also kind of serendipitous because even though I didn't have a lot of expectations, but I ended up really fine tuning and learning a lot about machine learning and specifically computer vision there. I think that, there's a lot of computer vision problems that, the Defense Department faces. And, I think in my time there, I probably touched every single computer vision problem, which prepared me very well for my time at iCardio. While I was there, I socially met, a friend, my co-founder and partner, Joseph Sokol, who really was the vision behind iCardio. And he knew that I had a machine learning background. So at first we would kind of talk informally. Then, I started consulting for him, and eventually, and I'll get into the reasons why, the opportunity was just so exciting for me that I jumped ship and decided to join iCardio full time as a co-founder.
That's great. Thank you, Roman. So iCardio.ai builds tools for everything echo to reduce time spent on echocardiograms and to reduce misdiagnoses. Can you tell us more about how the technology works?
Yeah, sure. So maybe before I tell you about how it works, so let me tell you about why we believe this is needed. So right now, it takes about an hour to conduct an echocardiographic exam between the technician and the reading cardiologist. This is a lot of time. This costs billions of dollars to the health system every year, and there's a huge staff shortage right now. So there's actually less cardiologists today than there were 5 years ago, and we're about 30,000 sonographers short of meeting demand in the US. And we believe that automatic AI tools could really help with that bottleneck. In addition to that, we're really trying to fight misdiagnosis and underdiagnosis just because of, burnout, fatigue, oversight. Doctors and technicians will just miss things. So 85% of the people who have HCM are never diagnosed. The majority of people with severe aortic stenosis who are eligible for a valve intervention never end up getting it. In particular, this difference, there's a 7-fold difference in valve utilization in areas with the highest population densities to the lowest population densities. So there's a big disparity in terms of urban, rural populations. There's also, it's well known that there's large racial disparities in who gets treated for these things. And we think that AI can help here as well. Ideally, we envision a world where in the future, every single patient who gets an echo will have an AI do a standardized automatic read that works the same on anyone and is relatively very low cost compared to a human cardiologist. We believe that that can dramatically streamline the workflow and improve the lives of patients. As far as how it works, so let me kind of start off with how an echo exam is conducted. Right now, you have a patient who goes into a hospital. A referring doctor will say, we need to see how his heart looks. Echocardiography, there's about 30 million echoes done each year in the US, is the forefront modality for screening for heart disease because it's relatively cheap and very safe compared to other forms of radiation-based imaging. And so you have a technician come into the room and take scans of the patient's heart from about up to 30 different views. He'll collect about 45 different videos, and then he'll spend a long time going through the videos, finding which videos correspond to what view of the heart, and then sort of manually annotating them to get quantitative measurements. Then he'll go on to his next patient, and at a certain time later, it could be anywhere, it's supposed to be under 2 days, but we've seen community hospitals where it can take as long as 2 weeks. The reading cardiologist will go look at the echo videos and the technician's measurements, and then do the actual diagnosis. So we would kind of inject ourselves into two spots in this workflow. First, we would help the technician. We would provide automated measurements. So he already is looking at, he kind of has the work done for him. He would only need to correct them if needed. And then also, immediately afterwards, we would generate a preliminary report. If there's any warnings that require a doctor to potentially look at the patient right away, where we can't wait around for 2 days to 2 weeks, we would alert the reading cardiologist. But in either case, by the time the cardiologist sits down to read the report, he already has the answers in front of him once again, and all he would have to do is correct anything. So that's kind of how it works on the workflow wise.
That's helpful. That's very labor intensive. I appreciate the background. And so your technology can read the entire echocardiogram and produce a cardiologist report more quickly. Any thoughts on how to fit this within the existing delivery system or where we're headed?
Yeah, sure. Let me just also kind of point out to something you said and maybe go a little bit more about how this company started. So our aim absolutely is to reproduce the entire cardiologist report. We're not the only ones to have to want to apply AI to echo, but I think that where perhaps we differ is our vision is not to do a measurement here or one pathology or diagnosis there. We really want to reproduce the full report. Just kind of going a little bit more into our origin story. We were a company that sort of started around a data set, as Andrew Ng, who's a very seminal deep learning researcher, kind of says, in machine learning, the algorithm is the rocket and the data is the fuel. So we started off with a lot of fuel. Our co-founder and original CMO, Dr. Josh Penn, he ran a telecardiology business for over 20 years, operating in over 20 states and over 350 centers across the country, where he collected a data set of over 150,000 echo studies fully labeled. That's over 200 million labeled images. And, when we first started, neither myself or my partner really knew anything about cardiology or echo. We just saw this huge data set, and, we saw that the reports that his company would deliver to the referring doctor, essentially their customer. And, our goal from day one was saying, we want to create an automated version of this. And so, where we are now is we have 40 tools for the interpretation of echocardiography, both for quantitative measurements where we, annotate a part of the image and say, this diameter is X amount of centimeters or Y amount of milliliters, as well as for the detection of over 30 different types of pathologies that are present in the heart, ranging from valve disease, atrial fibrillation, heart failure, etc. As far as how kind of this all works, we knew because of the sheer amount of models that we have to create to do this. Right now, we have over 40 production ready models for interpretation of the heart. We knew that we couldn't sort of train each model in a bespoke fashion, which I think is how a lot of other AI companies do it. They train one algorithm at a time. We knew that we had to create a very sophisticated AI infrastructure that can, sort of help us automatically train, manage, deploy these models at scale. And so, now it's gone to the point where we can specify the disease we want to go after. Let's say pericardial effusion, and with a click of a button, we can scour our database for relevant cases, upload them to the cloud, train them with our sort of secret sauce deep learning architecture that we already works well on this problem, and then validate on the holdout set, generate the relevant FDA documentation in the process, and then deploy it to an endpoint that's accessible for customers all over the world. And so this is a pretty automated process at this point that we're very proud of, and we've also sort of used for kind of R&D to help others as well.
Thank you. It's just super impressive and exciting. We also heard that you recently collaborated with Tufts University to demonstrate how machine learning can predict aortic stenosis. Can you maybe tell us a little bit about that project?
Yeah, sure. So I think I already mentioned aortic stenosis. I think it's probably, it's one of our nearest term targets because, it's well known that it's underdiagnosed, and there's a lot of kind of population density and racial disparities in it. And we already know that we can do it really well. So the collaboration with Tufts, with Ben Wessler, who's one of our advisors, we actually found them through this because they kind of published on this beforehand, and we reached out to them, and we worked together on the model. In that paper, they actually used our data set to validate their model on an external site. We also have a comparable model that performs very similarly. And the reason that this is really exciting is because aortic stenosis is traditionally diagnosed via Doppler imaging. But we did this directly from 2D or B mode echo, which has never been done before. And this has a lot of value. First off, while Doppler can be reliable in the sense that it's a very quantitative approach for classifying this disease, it can be occasionally hard for the sonographer to get the right Doppler angle, and there's no way to know if they got the right one, if they got the maximal jet or not. And so, we believe that this leads to a lot of underdiagnosis of AS. And so by doing this in 2D, which is sort of like a complementary modality, this could be another sanity check for the reviewing doctor to say, hey, it doesn't look like there's any AS in the Doppler, but this 2D is like really ringing a lot of alarm bells. Let me send the technician back to make sure that he did it right. In addition, there's what's called point of care ultrasound, which is a big revolution in the ultrasound space going back a couple of years now with leaders like Butterfly Network and Aquarius, where with the latest technology, we've been able to compress $250,000 cart-based ultrasound machine into something that costs a couple $1,000s, fits in your pocket, and connects to your iPhone. And so this really is creating a revolution in the sense that it's bringing echo outside of its traditional use environment in hospitals and further out into the community. And a lot of these machines don't have Doppler. And so that's why we believe that the capability just to detect AS from B mode is really going to open up a lot of doors there.
Great. And I'm curious, and I think I'm hearing some of my question answered in some of the comments you've already given, in that the approach here is really to augment and enhance the work of the cardiologist rather than replace the cardiologist. But can you maybe talk a little bit about what kind of reception you've got from cardiologists and how you've been able to work to build the confidence from these doctors to support your product and any challenges you may have faced with that?
Yeah, absolutely. I'll say cardiologists are our easiest sell. They're our biggest fans because I think they're on the front lines. They see all the issues. They know how much of a value add we can add, especially to their lives. Because at the end of the day, we're saving them a lot of time. And so they love this. So they're, it's IT team, the hospital administrators. They're kind of the more challenging stakeholders to sell. But with cardiologists, we work very closely with our clinical team to help build our products. And whenever we, pitch our product to new cardiologists, the first thing that we'll do is give them a demo of our product and also offer them the opportunity to upload their studies to our system so they can kind of build trust and confidence in our product.
And is your product largely invisible to consumers, or are patients, consumers generally aware of this functionality behind the scenes, and how do they interact with it?
Yeah, so we are our target audience are mostly clinicians, sonographers, and cardiologists. At this point, consumers wouldn't really. This would kind of be behind the scenes from their perspective. Because we are making quantitative measurements and diagnoses. So there's, as far as FDA is concerned, there's also limitations there. I think in the future, with the rise of focus, that's getting nearer and nearer to consumers. Potentially one day, we all might have one of these things in our homes. I think that potentially could bring us closer, but certainly not in the near term timeline.
Rogan, you mentioned that the toughest sell is kind of hospital administration and IT, and my thought is that's probably somehow related to the reimbursement challenges with the solution, but maybe you could talk about that and how this works from a financial perspective.
Yeah, absolutely. I think that, by way of background, when we started the company, we were perhaps young and perhaps too naive. We kind of thought we're going to make this amazing product that's going to help doctors, help patients, and, we'll figure out how this will get paid for and how to make money on this. Turns out, I think that's been one of the hardest parts of having a medical imaging AI company. And I don't think it's just us. I think that a lot of people in the space are sort of wrestling with the go-to-market strategy. It's not trivial to as far as who will pay for this. Like I said, cardiologists love us. They're on board, and then, we'll typically go to the higher ups and they'll say, okay, how much is this going to cost us? And is this going to make us money? And I think that our answers there, and took some thinking, but our answers there are twofold. One, I think that one is efficiency gains. We're going to save doctors time. They're the most expensive resource in the system, and their time could eventually be used to do other revenue generating procedures. So that's kind of the most obvious argument. I also think it's probably the hardest sell, because while it makes sense, there's sort of it doesn't manifest itself immediately in the hospital's bottom line. A lot of these, there's not an unlimited amount of cases that, if they finish their, these studies faster, they could read 10 more and thus directly increase billing. So the other argument, which I think is more powerful, is that it's well known that there's a lot of misdiagnosis, as I mentioned in the beginning. Not for every condition, but for a lot of conditions, the follow-up to after you diagnose is more follow-ups, more imaging, and more procedures, which can potentially be revenue generating. So, for example, in the case of aortic stenosis, the most common treatment is a TAVR, or an artificial aortic valve. That generates on average $120,000 in revenue for the hospital. So theoretically, if we find just one missed case of aortic stenosis that leads to a TAVR per year, that would pretty much pay for our whole product. Now, obviously, that also requires, I don't want to say mental gymnastics, but evidence. So we're in clinical trials now in 3 US sites, not just show that our product works, but also to kind of study our effect on the bottom line. Can we find these missed cases? Would they lead to additional revenue generating procedures, et cetera? So that's kind of case two. And then the third one is perhaps the most exciting is, you mentioned reimbursement. So when we started this company, looking at the reimbursement landscape, we assumed that reimbursement will eventually happen by payers, but we don't know when, and we're not going to build our company around that assumption. And so, all of the pitches we've done and all of our business models is essentially assume there's no reimbursement. But just recently, I would say the last month or two ago, probably 2 months, CMS just approved the first reimbursement code for an echo diagnosis of heart failure. It was for inpatient with NTAP, which is reimbursed at $1,000. Just for context, the professional fee for reading an echo is about $100. So this is a dramatic revenue increase. They also approved a new tech APC on the outpatient side, which was much more modest. I think that was I forgot the exact amount, maybe 100, like in the $100 to $200, but still approximately the amount that the doctor gets for reading the echo just by running it through the software. He can he can pretty much double his revenue. And so I think that this is really exciting for us. I think that this is dramatically going to increase adoption of not just our technology, but more broadly AI in healthcare in general. I mean, that's really what these what the NTAP and the new tech APC program are for, is to drive the adoption of new technologies. And I think about these are reimbursement structures where there's they do have an expiration date, but eventually I believe that there will be a more permanent reimbursement code in place. And I think that once providers can see the direct reimbursement, that's really gonna make things easier.
That's terrific, and it sounds like there's multiple avenues for both demonstrating ROI, which I think can be a challenge with a lot of these solutions in terms of the sell to administration. But then in addition, there may be some opportunity for more direct reimbursement, which is just terrific. Next, I was going to ask you a little bit about the company's trajectory, and some of our listeners are in the startup space, and just from the moment of kind of inception of a company through to profitability can be a long one. And so we're just curious of the story of iCardio.ai, how the solution evolved. You mentioned starting with a lot of data based on clinical work that had previously occurred, but how was the research and development funded? At what point in the past, if applicable, did you guys get to profitability, and how has some of that worked?
Yeah, sure. So so startups are obviously a roller coaster of ups and downs. Yes, and it's been a really fun, exciting, and certainly sometimes difficult ride. So yeah, we were, I'll say when we started, we were a true garage startup. This data set that I refer to was literally on a bunch of hard drives in Dr. Penn's basement. So probably the hardest from a product standpoint, the hardest part of the company was just organizing the data set in a way that was amenable to machine learning, just uploading, organizing it, etc. We started off with, essentially Word documents and PDF reports over multiple years with different versions, and just figuring out how to parse all that. Looking back now, ChatGPT probably would have been very useful for at least large language models, but we did it the old-fashioned way. So that was how the company got started. That phase of the company was largely bootstrapped. We had eventually we sealed a collaboration agreement with GE. It was a 5-year master services agreement to kind of help them do R&D on some of their algorithms. And like I said, our goal was never to be an R&D company, but when you have a startup, get money where you can take it. And so that not only helped us with funding, and it wasn't even we specifically negotiated that deal. It wasn't a huge amount of funding because we intentionally wanted to get our foot in the door, and it worked because that allowed us to seal our first angel round, which led to getting salaries, which was great. And then with that, we have been focusing on building our product and getting through FDA. So since we've been around, I believe that we have spent or raised probably probably around 1 to 1.3 million right now, and that's to organize our data set, build our product, and get it through FDA. So the biggest news for us is that we submitted to FDA about 2 months ago. We already got our first round of feedback back. So I would say that we're expecting clearance in Q1 of next year, but possibly still this year. still at the end of this year. We're also once we what in parallel with submitting to FDA, we also did TechStars, which is a startup incubator, which helped us a lot. And with that, we started raising our seed round. And so we're still currently in the middle of our seed round. It's going very well, but there's, it's still a work in progress. We have a lot of the round already spoken for. Quick plug, if anyone is interested, please reach out. But I at least right now, I would say, there's no danger of the lights going off. We have like a decent runway now with money that's already partially coming through this round. So I would say that I have never been as optimistic about iCardio as I am today. That having been said, it's a roller coaster. So, there was definitely times not too long ago where, our runway was in pretty dire straits, and, we were getting ready to take some pretty desperate measures. So it's certainly a roller coaster.
It's fascinating, and I know I'm appreciative that folks like you are out there working on these innovations that will really improve the healthcare delivery model going forward. I guess just to conclude, Roman, if you can just tell us what you're most excited about for the next 3 to 5 years, both in AI and medicine and for iCardio, what gets you up in the morning? What are you most excited about?
Sure, yeah. I would say two things. So on as far as medicine, and iCardio, I think, has its role here, is I already mentioned earlier POCUS, point of care ultrasound. I think that this is going to make a tremendous revolution in the way cardiography is done. And I think the real power of it isn't, I live in Los Angeles. There's wonderful hospitals around here where if I needed to get an echo, I could relatively easily get one. But when you think about the third world and rural areas, most people would never see a cardiologist their whole life. A lot of the world does not live anywhere near driving distance to a cardiologist. And, there's been studies where you can take POCUS and train a nurse in about a day on how to get how to do a basic echo exam. And they could take this out into rural communities, underserved communities, and conduct an exam. And then the remaining bottleneck is really just the human to interpret it. But I think this is where iCardio fits in. Now, even that isn't a bottleneck because you can use AI to screen cases and say, out of these, 1,000 cases 1,000 echo studies that you've done, these 7 really need to see a doctor, and kind of triage them that way. I think, at the end of the day, I think that if we could address that need, that's at the end of my life, that's what I'll be most proud of doing, because I think that it really will save a lot of lives. And then the other thing that I think is really exciting in our space is the rise of large, technically like foundation models, large language models, generative AI, et cetera. This is really almost made, I don't want to say obsolete, but, is the next generation of AI. And I think that this adds a lot of capabilities. There's a study by Google that I'm really excited about where, they trained a network that you could actually converse with about a medical exam. So it'll read, understand all the images in the study, give you the conclusions, but then you can actually ask questions like, hey, AI, I'm a doctor. I don't see, you said that this patient has this condition. I don't see why that's the case. Can you please explain to me why you think so? And it'll pull up the relevant video, the relative frame in the video, the relative part of the frame, and say, this is why I think, why I made this diagnosis. And then the doctor can agree or disagree. So I think we're kind of moving into a much more intimate collaboration between clinicians and AI. And, I'll say again, if there's any doctors listening, obviously doctors, the ones that are listening, at least you guys never make mistakes, but there's a lot of doctors in the world, especially non-specialists, who might interact with these images when there's no specialist available, that don't have the years of fellowship training, and a tool like this will dramatically help them make better decisions.
Amazing, great, Roman. This has been just fascinating to me. I'm very excited to watch your company grow and continue its trajectory. Do you have any closing comments? Otherwise, we're going to thank our listeners.
Yeah. I want to first thank you guys. This has been a a really great conversation, and thank you to the listeners as well. And if anybody has any questions, you feel free to reach out anytime.
And what's the best way to reach you, Roman?
Probably by Twitter, or just by email. I'm Roman at iCardio.ai. Feel free to shoot me an email or reach out to me on Twitter or LinkedIn.
Wonderful. Roman, thank you so much for your time. Thank you to our listeners. Again, this is the Health+Tech podcast, hosted by myself, Holly Buckley, and my partner, Kristen McDermott Woodrum. You can find both of us on the McGuireWoods.com website. I would love to hear from you. Thank you so much.